drugs and new therapies. The geriatric population, which starts at what age? 65. So people are living longer, and that, as pharmacists, as healthcare providers, we have to be also aware of some of that living longer. What are some of the complications that occur in that population, or what are some of the disease states, or what are some of the syndromes? And so in the geriatric world, some syndromes that are referred to in the geriatric population, I've listed them on the board. Constipation doesn't sound like a big deal. It's constipation. People get constipated all the time. We take medications that can constipate us. What medications can cause constipation? Opioids. Any other medications? Anticholinergic. Anticholinergic agents can cause constipation. What are some anticholinergic drugs? Atropine. Huh?
That's what you said.
Okay. What other drugs that are anticholinergic? Scopolamine.
Yes.
What other drugs, guys? What other drugs? What other classes of drugs? Antidepressants. Which ones? Tricyclics. What other drugs? Benadryl. Yes. Antihistamines. First generation. Benadryl. Antihistamine. What other drugs? Cogen. Yes. What other drugs? Antipsychotics. Yes. So you have to be familiar with the fact that as we age, one of the syndromes of aging is constipation, but also some of the drugs that we use, everyday drugs, maybe not atropine every day, but some everyday drugs that we use can contribute to the constipation to a patient that already may be experiencing constipation. As we age, everything tends to slow down. Everything slows down. Blood flow to the liver, so the metabolism, the rate of metabolism slows down, the rate of elimination slows down. That whole process can slow down, which typically this population do have bouts with constipation. It can be so severe that we'll have patients come to the hospital, severe abdominal pain, and last week we talked about this disimpaction, but oftentimes this happens in this population. Maybe not in the young old, 65, because most times they're still within, moving and grooving, but as we age and get older, 70s, 80s, that is a big deal, constipation. We drink all this water. I see every other person got something to drink, drinking on water and stuff. But as we age, that whole process of just thirst and wanting more water to help hydrate the body, that all slows down. So they're not taking in as much water. They're not they're not doing as much physical activity. So that can contribute to the constipation. So it becomes in geriatric world, it becomes what we call a syndrome. So we go ahead and treat that. Dysphagia is also a syndrome in this population. Difficulty swallowing. Some have quoted that, after taking so many medications, for whatever reason, because as we age, we may have more medical conditions, and conditions such as, what medical condition can one have which will require you to take multiple medications to treat it? Off the top of your head. Hypertension, what else? Diabetes. What else? CHF. So if you got hypertension, CKD, if you got hypertension, remember as we age, we tend to have more medical conditions. So if you have hypertension, CHF, diabetes, that alone, you may be taking 10, 12 pills at a time, considering whatever that condition is. And I've treated some older adults, and they're like, well, why don't you? Because what malnutrition is an issue. And so it's like, why aren't you eating? And they will report that after taking those 12 pills that morning, they were full. We can't wrap our heads around it, but this is everyday life as we tend to get older. As we tend to get older, we don't eat as much as we do now. We don't drink as much, and it happens in the geriatric population. So, nourishment, nutrition. A lot of times you'll see them with Boost and Ensure. They are encouraged to have those supplements readily available because they just don't have the appetite that they need. Also in this population, hypoglycemia is a big deal that will end them up in the emergency room, syncope, passing out, all of these things because they didn't eat, but their good pharmacist told them, you better take this diabetes medicine, but maybe they didn't finish that statement by saying, make sure you eat, when you're taking this medication, so that you don't get your blood sugar doesn't get too low. And so back to counseling, pharmacists, that's our role, that's what we do. So that's another issue. Pressure ulcers. Anybody know what a pressure ulcer is?
Pressure ulcer ulcer that resulted due to
Yes.
Like a bed ulcer?
Yes. Yes.
Bedbound.
A bed sore that can be from someone who is bedbound. Oftentimes we see what population of patients that may be bedbound? Geriatric patients may be bedbound. When you go to the nursing home, big deal. Anybody been in the nursing home before? Everybody? You go in the nursing home, and back in the day, they would have, you could see patients just sitting around, or maybe just in their bed all day, or in the wheelchair, slumped over, and things of that. That's not what's supposed to be happening, but the pressure ulcers, the sores, Google it. Google pressure ulcer, a picture of what a pressure ulcer is. Take a few minutes and Google that. Tell me what you see. You don't want to look at it. You don't want to smell it either. It'll light up the whole room. But that happens when you have that patient laying around, not moving, and the skin, as we age, everything is slower and everything is not as thick. Skin is thinning out, and it's so easy for those things to happen. Yeah, it's not pretty. It doesn't smell good either. And again, when you hear them talking about the patient needs to be moved or turned every 2 hours and things of that, that's what we're trying to prevent. Because remember, as we age, everything changes, and the skin is easier for the skin to break down. So if you're just sitting in that one spot on that one hip, then you can get that. Or on their bottom, or in the wheelchair where the heel of their foot is just on that chair. Just, and if you're already dealing with diabetes, what else happens with diabetes? What is one of the complications of diabetes?
No healing. Healing difficulty.
Well, they get wounds as well. But
healing.
Infection, yeah.
What else?
Well, they have
retardation.
Nerve pain. And with the nerve pain, do you have great perfusion?
No.
Okay. So if you're just sitting in the bed and sometimes you're just laying in the bed, the heel of the foot or on the wheelchair, and that thing, the ulcer will start there, and it starts something very simple, just a little redness. And if it's nursing staff or family or whoever of not being as attentive, that little redness turns into what you see when you Googled it. That's a big deal. So somebody said something about infection. That will cause, if it gets as bad as sometimes it gets to the bone and the patient is septic, and it can get really, really bad. And then that's when you start getting into this neglect. Because somebody wasn't paying attention. Because Mr. and Mrs. or grandma or mom or dad or whatever wasn't getting up out the bed, wasn't moving around, and somebody kind of left them there. So that's when we get into this. That can get you an APS case, just like you have CPS, we have APS. and they can get you an APS case. They're not eating properly, so they don't have the nutrients they need for that to heal. Failure to thrive. Just general failure to thrive as we age. And we're not talking about right at 65, because I know some wicked 65s. I have relatives that are, I have an aunt that's 80. She'll be 90. And I said, she told me something about she was coming from church drive. I said, Amy, are you still driving? And she was like, yeah. And she's 90. She'll be 90. And you're like, and she about this tall, and she's driving a truck and stuff, but she's, I don't go far. I'm like, but what we don't want to do is we don't want to take anything away from the fact, because that's part of her initiative. I mean, she can still drive. She can drive to church, drive to the community center, very active in the community and everything, even at 89. But sometimes it's not like that. Sometimes it gets to the point where there is just a failure to thrive, a failure to just want to get up. My grandfather lived to be 102, and which was her dad, and he turned 102 that September, and he just said, I'm tired.
Wow.
So his diagnosis was failure to thrive, because he didn't want to eat anymore. He'll talk to us. He knew who we were, but he didn't want to get out of bed anymore. He was just, he said, man, Shaq, I'm tired. And he stopped. And he went on hospice. And you don't have to be just, this life-threatening, whatever, I don't know, but failure to thrive at 102 can get you hospice. So he had home with hospice, and everything, in God's timing, he passed 2 months later. But it was lots of insured, because he didn't want to eat, and nothing was painful, nothing was bothering him. And again, all of us came around. He knew everybody, and he was able to have conversation. He was just tired. Failure to thrive.
I think that's a wonderful way to go. No pains, no aches. I love it.
None at all. We all went. There's lots of, my grandparents had 12 kids, and then the 12 kids had at least 3 or 4 each. And so everybody was just in and out the next couple of months, taking turns to go. We called him Papa, and we were just there with him, and again, it was so amazing, because even though he failure to thrive was the diagnosis, he knew and held conversation with all of us. He just didn't want to do the walking anymore. He didn't want to do anything. And after 102 years and living through all of this, he was tired.
Did you say he has 12 children?
Yeah.
Wow.
Sorry, you had 12 children. Yeah. What happened? When he turned 102, he verbalized that he was just tired, so he didn't want to. Before then, he would get up, he would go for little neighborhood walks. Had a little garden out at my aunt's house, and wasn't doing cooking and things like that. She was doing that for him. He dressed himself and all of that kind of stuff. He just said he was tired. No, he wasn't depressed. He was full. Remember, I said he knew everybody. He had conversation with everybody. He just was tired. That was his words. I'm tired. He lived through, farming and 12 kids and, I don't know how many cousins I have, but, great grandkids and great grandkids, and, he just, said he was tired. This was in 07.
Yeah.
So, osteopenias, that's another syndrome that geriatric patients experience, another term, another condition that occurs as So we encourage, to take the vitamin D and those vitamins and things, to the calcium, try to encourage those supplements. But again, you have patients who are living longer, have multiple disease states, and then we gotta add vitamins and things of that nature. That gets to be, and some of those vitamins are pretty big, and sometimes that gets to be a bit much. The dysphagia, sometimes pharmacists, we gotta be a little creative with our older adults when you see them with all these pills, and maybe we can't give everything orally. So, compounding pharmacy is a great practice, and also as pharmacists, future pharmacists, think about these things. Patient, they don't complain much. I'll tell you that much. Most of them don't complain much. They just do what they can, and they just won't say a whole lot. So you gotta ask questions. You gotta ask questions to get them to find out what's really going on. Questions as simple as, do you take your own medicine or does someone give it to you? That's how you assessing adherence. Because if there's a daughter, granddaughter, somebody that's giving them the medicine, you're assuming that they're compliant. If they're at 87 years old and they're taking their own medicine, it might be safe to assume maybe some things are missed sometimes. Maybe not, maybe so. We're not accusing, but we do can have some lapse in memory and things of that. What's gonna bring us to the Beers list? What do y'all know about the Beers list? Who is Dr. Beers? Named after Mark Beers. Who is Dr. Beers? Y'all ever heard of him? Y'all been doing any research before today? It's okay. I like talking about Dr. Beers. Dr. Beers, if it was not for him, we would not be where we are today with how we even treat our older adults. And he was a geriatrician back in the day who was rounding with his team, his medical team, and they rounded mostly only in the nursing homes back in 1991. So just like you guys go on rotation, the medical team goes on rotation. These doctors, he was a geriatrician, so he only treated patients 65 and older. And so they, doing their thing, they going over to the nursing home. They noticing when they walk in the nursing home, everybody's slumped over, sleeping, the nurse is coming up, Dr. Beers, so-and-so fell last night, so-and-so is constipated, what do we do, what's going on? So they started noticing, what is just this trend, what's going on? So they started looking closely at the medications, eventually, and they noticed that the people that with the same complaints of the constipation, the delirium, the falls, and these falls can be detrimental in our older adults. So they noticed that those people that were having all these syndromes, they all had similar medicines on their profile. They all had these medicines that we all thought were so safe, which they are, but not for the population because they were causing them all of these things. Things like Benadryl, things like diazepam. We were giving Benadryl in the nursing home at that time. How many people take Benadryl for sleep today? Yeah, it's over the counter. It's all over the commercials. Take it. And some people may take it for allergies and itching and things of that. Well, it's a safe drug. It's been around forever. And in the nursing home back then, 1991, some of you probably wasn't even born, but they were using it for sleep, not knowing, because remember, it's safe. And we didn't have amlodipine and all of that stuff, and we didn't have those kind of drugs. So we used things like diazepam for sleep, insomnia. We used Benadryl. We used those drugs we used amitriptyline. Somebody said amitriptyline. We used it for sleep back then. Peripheral neuropathy. We used drugs like your tricyclics for that. But also, we talked about it, tricyclics are anticholinergic in nature. So again, they noticed that these same drugs, so they grouped them all together, and they were like, you know what, they're medications to do these things, and that's not what we want. So that's how the whole Beers criteria and the whole Beers phenomenon got started. And so they published that information, and people were still like, I don't really treat, in general, medical world was just kind of like, well, we don't really go to the nursing home, and they didn't really buy into it, because it was like, oh, okay. So the nursing home, the geriatrician community, the American Society, the American Geriatric Society, which is like our AGS, American Geriatric Society, is like our ASHP. They're like the governing body of some of our clinical practices. Well, AGS is like the governing body for doctors, pharmacists as well. I used to be a member, but clinicians who treat geriatric patients. And so they were like, okay, so in that little community, no specific clinical guidelines came out, but in the geriatric world, they were like, you know what, they are onto something. We are starting to notice that. And these falls are a big deal, and the fall and the sleepiness and the confusion. So they may be onto something. So in 1991, that kind of went on for a few years, where he was getting a little traction around the States, but not a whole lot. Then around 1997, it was the Beers criteria, or you might hear it called the Beers list, was adopted by CMS, and it was for all elderly. All elderly. It applied. In 2003, it's a big deal. That was around, so you want to pay attention to your politicians. You do want to pay attention to some of the things that they put forth, especially healthcare initiatives, because this was a big deal. In 2003, they were like, you know what? And when I say in 97, it became part of the regulation. It became part of the nursing home regulation. So as a consultant pharmacist, those that are interested in consultant pharmacy, they were able to come in and actually ding. Nursing homes get report cards, and they were able to ding the nursing home saying, hey, y'all are using too many of these drugs that are deemed inappropriate. Y'all are using too many, your patients are sleeping too much, they're falling, they're confused, they're constipated, and you got all these bad drugs. They could ding them. That was a big deal. And when family members go, wow, that was such a big deal, because when family members are researching the nursing homes for their loved one, that pops up. Might not be such a good choice, because they have this record. In 2003, when Medicare D came around, that was under the Young Bush administration, it was a big deal, because now they were like, you know what? If the patient is on Medicare and they're trying to use that Medicare money to get certain drugs that were deemed inappropriate, we're not going to pay for it. The science has proven that this isn't working for people 65 and older. So they can't stop them from getting it, because some of it is over the counter, but they couldn't get it through their Medicare. In 2012, it was another great year where it was further adopted into quality measures. More quality, so the better the facility, the least of these drugs that they use, those highly anticholinergic medications that they use. In 2012, the intent got bigger, because remember I said before it included all elderly, but now it included, in 2012, it included ambulatory patients that lived at home that were 65 and older, and patients that were in institutional settings, hospitals, rehabs. It included everybody, and it targeted the practicing clinician. Doesn't matter, pharmacists included. The goal was to improve care by reducing exposure to PIMS, potentially inappropriate medications. And also now, we took the Beers list, which I never posted. I'm sorry, I will post it. We took the Beers list, the Beers article, the Beers list, and we bring it into the nursing homes. We bring it to the pharmacy students. Well, pharmacy just not catching on, but we brought it to the medical school students, and we said, here, you need need to learn what these potentially inappropriate drugs are. You need to be familiar with these drugs and these drug classes. Some of them are things that we use every day that population actually needs, but now some of them we have to use with caution. We can't just go and use. So what's our drug of choice? What's our class of choice for depression? SSRIs. Okay, can we use any SSRI in our older adults?
Not any.
Huh?
Not any.
Is there anyone in particular we want to reconsider? Paroxetine, because it has the most anticholinergic side effects. So clinicians, that test is coming, and when that test say, maybe not my test, but when you're reading your case study and it tells you, 85-year-old newly diagnosed with depression, and then they give you a list of SSRIs, you gotta know that paroxetine of the SSRIs is the one that's most anticholinergic. And that's not the one we're gonna pick, even though we do need to pick an SSRI. Again, what was excluded from the Beers criteria, was always excluded, is patients who are palliative or under hospice care and there are no alternatives. There are situations where there are just no alternatives. So what do we do in those cases? Well, how are we going to make the exceptions? What are we going to do different pharmacies? What can we do differently? Start low and go slow. Start low and go slow. So some are like, you only on 12.5 for so long? Well, that's maybe all what they need. And then we just titrate. Whereas a younger adult, they might get started on 2550 right away. I think the guidelines say something like that. But an older adult may be at 12.5. We break a lot of pills in half if we can, if they're scored. What does it mean to be scored? What does it mean to be scored, the tablet?
Just one is broken in half.
When you can break it and it's evenly distributed on both sides. So we do a lot of that in geriatric care. We do a lot of that when it's not available in the smaller doses. was a big deal for the Beers list. It was a really big deal. We were so excited. I mean, it was like, oh my God, people finally get it. You know, they finally get, we got backing that this is a big deal. So over at the facility where I used to work full time, we had, we deal with heart patients. We deal with hearts. We doing cabbages and, you know, bypasses, and we doing, you know, we're focused on the heart. But the population of people that are admitted at any given time in the hospital beds are typically, acute care hospitals typically have 40% of the patients that are 65 and older. If 40% of the patients that are 65 and older, even if they're coming in for heart transplant or whatever, they probably got a whole bunch of other medical conditions. They got other things going on besides that heart. So in 2012, we also noticed, like, hold on, we got a lot of people falling. And again, remember that report card I told you about? You guys can look up in the, right now, you can look up the report card for the hospitals in the medical center, and you can say, you know, for elective stuff, I don't want to go to that hospital. Everybody go there, they fall. Or everybody go there, they don't come out alive. You know, you can, that information is available. And so the hospital started, you know, back to, some of the Bush administration, some of the things that came out of that was that if your hospital was, if the patient was experienced, if you had lots of falls at the hospital that they deemed as preventable, which a fall related to a medication, that is deemed as preventable, because there should have been pharmacists around and prescribers who knew enough about beers and knew enough about their patient, and it should have been pharmacists around to catch that. That's a preventable fall, but some of those falls in our geriatric patient can be detrimental and lead to death. So they cannot pay for that hospital stay if that patient experienced a fall. So you could come in, you can get your whole surgery, and then you have this nasty fall, break a hip or whatever, and when they do their research and say that this was a preventable fall, then you gotta eat the costs. So some of this that we do, guys, it comes back to money, the bottom line. And so the institution was like, you know what, we got too many problems, we gotta do something. And so we focus on these we get these heart transplants, we're doing what we need to do, but we put these pacemakers in, but our patients are falling. And at that time, we had a small team we had a geriatrician on the staff of all the pharmacists in the whole institution. We only had one pharmacist that was geriatric certified, that had studied and all of that. So I was literally handpicked to go to this administrative team and work with them on how do we, as an institution that's focused on heart transplants and heart, what do we do different about our how we're treating our patients? How do we go and tell the cardiologist that you can't use clonidine anymore because it's on the mirrors list? Well, we really can't do that in a heart institution. So what we did was we realized that our in general, people just didn't know about the population, and they didn't know how some of these drugs, these PIMs, potentially inappropriate medications that we use every day, they just didn't realize the impact that they may have on elderly patients. Things like diazepam. Diazepam is, what type of side effects do you have with diazepam?
Confusion.
Dizziness, confusion. What else? Huh? Fall risk, increased fall risk. What else?
Puts you to sleep, right? So it doesn't.
Oh, yeah. Increased sedation. What else? In general, what type of side effects have you called out?
Does it provide depression?
Anticholinergic. Why is this a big deal? Why is that drug such a big deal? We can use it for seizures. We can use diazepam for so many different things. So why is it a big deal in the elderly? What's the half-life?
Long half-life.
Very long acting. So if it's so long acting, and then you got all these side effects, what are we doing our elderly people? And it also diazepam is highly plasma protein bound. What the slide or 2 or 3 before, we talked about malnutrition. So what plasma protein are we? Albumin. So if diazepam is highly plasma protein bound, and the patient potentially has or is malnourished, and they have a low albumin, what do you think is happening with that drug? It's more free drug, but you already told me it got this long half-life. So you got, due to the kinetics of that patient, the dynamics of that patient aging, you got this highly plasma protein drug, you have a decreased plasma protein, you have it hanging around a long time. So what do you think is happening what do you think was happening when we just casually had that drug, a free-for-all for all patients? More toxicities, more side effects, more falls. So we tackled things that we could, small things. So what other option might we have in your benzodiazepines that we can use instead of diazepam? Say what? Say it again. Lorazepam. Shortest acting. So lorazepam, what's the brand name? Ativan. So that was easy. So hey doc, so we made up some little things in the chart. So when they would order the drug, it it will give them, instead of using diazepam, let's try lorazepam, because lorazepam is shorter acting. Doesn't mean it doesn't have some of those side effects as diazepam, but the fact that it's shorter acting, at least we can get a hold on it that way. Okay? So in 2015, we had more updates. This thing, it gets more exciting. So I'm waiting now for, I don't know what happened to I think we were supposed to get some updates early 2022, and I don't know, maybe I missed it. But 2015, we had more updates to the Beers list. Now, mind you, from 1991, that list has grown from, 5, 10, 15 drugs, it's grown. And now, 2015, we're talking about medication, we're talking about classes that can cause potential problems. Doesn't mean we can't give them, because we still might need to give them, but we need to be aware that it can cause potential problems in patients 65 and older. We classified the drugs into 5 categories. Medications considered potentially inappropriate in older adults. Medications considered potentially inappropriate in adults with certain diseases or conditions. So drugs that are renally cleared. So now we have, if patients have renal impairment, so now you need to be paying attention to that. Medications that are considered potentially inappropriate based on kidney function. Medications that should be used with caution are now on the list. Drug-drug interactions that are highly associated with harmful outcomes. So then, this is when they start matching up. If we put a benzo and an opioid, then what can happen to our older adults? Benzo, opioid, together. I'm 75 years old. What do you think we're doing there?
Constipation,
Depression, respiratory.
All that. So now, you have a guide with that Beers list, you can say, you know what, these combinations can potentially cause all the things we don't want. And so we need to be mindful of that and mindful of that and use with caution. Doesn't mean we can't use it. Don't leave the lecture saying we can't use none of these drugs, because some of them you don't have a choice. But we can, start low, go slow, and pick a different agent in that class if we need to. The goals in 2015 was intended for all ambulatory and institutionalized settings of care for older adults in the U.S. The criteria was to improve care by reducing exposure to inappropriate drugs or medications, serve as an educational tool, and use as a quality measure. So now, it's actually, it's listed. It is if your institution or your, especially in nursing homes and things, if they're using too many of these drugs that are deemed as inappropriate, or too many of the combinations in one patient that's deemed inappropriate, now people looking at you sideways like, wait a minute, what's happening? Are you setting that patient up for a negative outcome? That's not what we want. And as families are looking for institutions to put their family members in, whether it's a nursing home or rehab facility, now they have access to that because that's part of the quality of their facility. On the Beers list, it gives you rationale, recommendations, and quality of the evidence, and the strength of the recommendation. 2019, noteworthy changes. Opioids and benzodiazepines puts the patient at risk of overdose. What was removed from the criteria in 2019 was drugs that were no longer available in the U.S. So, wasn't a whole lot, but cocaine was removed and pitazazine was removed. Oral decongestants was taken off the Beers list. Oral decongestants was taken off the Beers list. What kind of side effects do we have with pseudoephedrine and phenylephrine? Say what? Say it. Increased blood pressure. Yes. That's gonna happen whether you're 65 or 25. So they took that off because it may happen in anybody. So again, we have to use with caution with anyone, and so it was taken off the beers list. Vasodilators. What happens when you use a vasodilator? I had this talk with my P4 yesterday. Let me make sure y'all give me some information today. Huh? Hypotension.
Fainting.
Fainting. Yes. So can that happen with all vasodilators? Is that potentially a side effect for that class of drugs?
Mostly.
Potentially.
Yes.
So it was taken off the beers list. What's not included on the beers list is drugs with risk not unique to the elderly. The purpose is for potentially inappropriate medications is to be specific to elderly. Drug-drug interactions. That's not unique to elderly. So that's not on the beers list. Drug-drug interaction is gonna happen, but it doesn't matter. List of alternatives. So oftentimes when you tell the doctor or you recommend that that drug is on the beers list, you also need to be prepared for what's clinically appropriate option. The beers list doesn't give you another alternative because it's just too much, it's too complicated. And remember, you have all these clinical guidelines, and so it doesn't, that's ever changing, so it doesn't give you an alternative. It's just too complex. But as clinicians, as future pharmacists, about to go out on rotations, one last year to go, you have to put your thinking cap on and look at and really identify with the patients that you're treating. Everybody's not the same. And the guidelines say they are the guidelines, but also when you're looking at the guidelines, you gotta factor in this person is 75. They already prone to constipation, confusion, all these other geriatric syndromes. If I give them this drug, even though they have this peripheral neuropathy with the diabetes, if I give them the amitriptyline, which I can, what is that gonna do to my 75-year-old? That gonna make them better all of a sudden, or is that gonna worsen some of the conditions they already, or syndromes they already experiencing? Pharmacists, that's how we have to think and tackle our patients, our patient care. Just because Tylenol PM is readily available over the counter for any and everybody to take, when our elderly patient comes to the counter and asks for something for sleep, is that the best option? Advil, what about Advil PM? Is that a great option? They told you they were experiencing insomnia. It's over the counter. Pharmacists?
Do we also need to be mindful of kidney and liver when prescribing those kind of medications?
But what is Tylenol PM?
Or sleep?
Diphenhydramine.
Yeah.
What is Advil PM? Benadryl again. Again, the manufacturers, this is what they do. Tylenol is tried and true. We know it works. And people identify with Tylenol because we've been using Tylenol since creation. But we gonna stick a little Benadryl in there and we call it Tylenol PM. Our average person doesn't realize that PM is actually Benadryl that can contribute to a fall in an older adult, or confusion, or sedation. But it's over the counter. As the commercial said, just try it out. So as pharmacists, we gotta be aware of that and be able to help direct our patients. So what over the counter could we potentially recommend to our patient if they were experiencing insomnia? Melatonin, perhaps. We can do that. Start low and go slow. These are a few sample of Beer's recommendation and rationales. I put this one
being used.
Huh? Just what it says, the Russian increased greater risk of bleeding. So we have more GI bleeds and things that lead people, the common things that will lead people acutely to the hospital. GI bleed in the elderly, falls, confusion. They even come in. Grandma is just fell in the throb. She won't get up. She won't do that. Sometimes they're just so sedated. They have so many medications, so many things that are compounded there. Insulin sliding scale is another one. Hypoglycemia. Maybe they didn't eat, but they still took their insulin. The risk of using a sliding scale insulin. So now it's not that insulin is a bad drug, but the risk of using a sliding scale. Now remember, there may be some cognitive impairment as we age. We slow down a little bit. Not that we can't learn and just learn at a slower rate, but maybe it gets a little confusing that if your blood sugar is 400, take 2 units. If it's 300, take 1 unit. That may get a little confusing. And maybe they take too much. So the sliding scale of it is what's deemed as inappropriate. And we want to avoid doing that, the home sliding scale for the patient in that population. Strong evidence. Aspirin, again, risk of bleeding, in peptic ulcer disease, especially in people greater than 75 years old. There is a recommendation. You can use a PPI. It may reduce but does not eliminate the risk. Very strong evidence, very strong recommendation. Back to those oral hypoglycemics. Glyburide. What about glyburide? What about that class of drugs?
They dip you in that.
You have to eat. And what else? Kinetics. What about what's with the kinetics of that drug? Of that class?
Does it have long half-life?
Long half-life. Say it loud.
Long half-life.
Yes. Yes. And so longer half-life than the other newer agents. So that group kind of fell out of favor, especially in this population. So greater risk of severe prolonged hypoglycemia. You sighing? You okay?
Yes.
Huh? I love working with the elderly patients, and just this picture just touches me so. Everybody's smiling and happy, and we want to keep them right where they are, whatever that baseline is. We don't want to give them, as pharmacists, we don't want to give them any drugs that's gonna take away whatever it is. My aunt is almost 90 and she's still driving, so we don't want to go give her a drug that's gonna slow her down from her everyday going to the community center or going to the church and things of that. We want them to stay as independent as possible. That's what you want for yourselves. We want the same thing for them. Whatever they want to do. They've lived life, they've had great lives, and they should, just because they're older doesn't mean they just have to be bedbound. And we have to be aware enough about how the aging process and how these drugs may impact our older adults. Any questions, comments?
What would you like?
You really need to be able to articulate what the importance of the beers is. How we got to it, not necessarily, but you do need to be aware of what it is, why we use it, why is it so important. You need to be familiar with What's the intent of the beers list? I haven't made the questions yet, but off the top of my head, the general concepts of what, what's going on as we age, and the concepts of hospice and what it is, how pharmacists can play a role. What is our role at that point? Do we have a role? Is there a difference between hospice and palliative care? What are the syndromes? You may have a question that has something about the syndromes, and you may have a drug in there that we've talked about today that can be a shadow over one of the syndromes, but that drug can be just as impactful to the patient, so we want to not recommend it, or we want to change the dose or decrease the dose of those drugs. You're gonna get some questions about anticholinergics and how they may be helpful or not helpful in our older adults. I'm not gonna test you over the old medication. I think I said this last week. Old medications for new uses in the hospice setting. Goals of hospice care. Some of the pharmacokinetic, pharmacodynamic changes that occur in the life also occurring as we age, so you need to be familiar with that. When is beers this appropriate? Who does it impact? Is nursing home patients? Or everybody, anybody? All settings? One setting, two setting? That answer your question close to it? Don't worry. You'll be okay. I will post the beers list for your reference. I will post it for your reference. Any other questions? What's the